Hi, everyone. Morgan DeBoth here at BDSRA. I serve as the Vice President of Support and Advocacy. This session of Ask an Expert is brought to you by the Rare and Ready Initiative. I'm joined today by Carrie Lotto and Ken Sprague. If you two would like to introduce yourself.
Sure. Hi, everybody. Carrie Lotto. I'm Director of Policy and Advocacy at RX for Good.
I'm Ken Sprague. I'm the Head of State Government Affairs at BioMarin Pharmaceuticals.
Wonderful. I would just like to welcome everyone today. If you have questions, just as they come along, please feel free to drop those in the Q&A section if you're joining us via the Zoom webinar. And then if you are joining us via Facebook Live, go ahead and drop your questions in that chat box on the live, and we will get those answered to you just as soon as they come in. And I will go ahead and share my screen. The two folks were kind enough to put together a slideshow for us today, so we are going to get started.
Morgan, should we go ahead and wait for a couple minutes for more folks to log into the webinar, or do you want me to just jump right in?
I would go ahead and jump right in. It is being recorded and it's Facebook Live, so we're live at least on 2 platforms.
Okay, perfect. Great. You can go ahead and go to the next slide. I just want to thank everyone so much for joining us tonight. We are excited that BDSRA has hosted this webinar for us to talk about Medicaid access to treatments, hurdles, and then how to get involved. Again, I'm Carrie Lotto. I'm Senior Director of Policy and Advocacy at RX for Good. I'm joined with Ken Sprague, who's the Associate Director of Government Affairs at BioMarin. The rare disease community really holds a special place in my heart. My husband was diagnosed with a rare disease 2 months after we were married. It took him over a year to get diagnosed. And since then, I have worked to bring changes to policies that negatively affect the rare disease community. And one of these policies is Medicaid restrictions on rare disease treatments. So tonight, Ken will dive deeper into the specifics of the policies, and then I'll go ahead and discuss what we can do as a community to change those policies. We can take questions after each of our presentation, or you can type your question in the chat. So I'll go ahead and pass it to Ken to get us started.
Great, thanks, Carrie. And just to echo Carrie's comments, I appreciate everyone having us here today. We're excited to be with you. We're excited to talk more about some of the issues that are pressing with respect to rare disease therapy access in Medicaid. Thank you again. So with that, next slide, please. Next slide. So just to provide you a little bit of an overview of kind of the Medicaid landscape and how, rare disease kind of fits into that landscape. Obviously, I think a lot of you would be familiar with the Medicaid program. So obviously, it's a state-federal partnership, drawing both funding from the federal government and states, and does provide healthcare to lower income individuals. Obviously, based on the federal poverty limits, and there's certain exceptions within that. Specifically relative to some of the provisions that passed as a part of the Affordable Care Act, but that's generally the program. Every state has their own Medicaid program, and while there are many pillars and provisions that each state has to include within their Medicaid programs, they still can vary quite a bit by state. But just again, to give you a little bit more of an overview of how rare disease fits into Medicaid, about 48% of children with special healthcare needs and 45% of non-elderly adults with disabilities are covered by Medicaid. So we typically see a disproportionate share of those individuals living with rare diseases that are Medicaid patients. Nearly 2/3 of Medicaid and CHIP-only children have special healthcare needs and live in a household that does have an income below that 138% of the federal poverty limit, which for expanded Medicaid states is really the threshold for when you could receive Medicaid. Certainly, as I'm sure a lot of you are probably appreciative of the pandemic, COVID-19 certainly had a dramatic impact on Medicaid. millions lost jobs, a lot of other challenges and hardships occurred because of that. And due to that, Medicaid rolls and enrollment increased dramatically. Some have suggested even by up to 15 million patients. The interesting thing is going to be really as this pandemic kind of winds down, and I think we're all familiar and appreciative of the concept that the wind down of this pandemic may take a little longer than we thought, but I do think at the same time, changes will happen to Medicaid as some of these public health emergencies orders go away, and what's known as so as these public health emergencies go away, there will be significant changes to Medicaid rolls, and so they call it redetermination. So redetermining a person's status within Medicaid. And states are going to have to undertake this, and it's potentially going to create challenges from an enrollment standpoint, and something that states are certainly going to have to think about and work through. And so, something that we are very interested in as public health, policy advocates. So, next slide, please. Now to give you a little bit more of a granular look at prescription drug spending and budget impact with respect to rare diseases in Medicaid. So spending on prescription drugs has obviously over time it's kind of gone up and down. It's had a lot of interesting points where there have points of inflection where there have been increases and decreases to overall spending as a proportion of overall healthcare costs. But for about 30 years, from 1980 until 2006, prescription drug spending increased pretty dramatically per the Congressional Budget Office. But then after 2006, actually, the availability of generics and market competition really drove down that spending as an overall percentage of healthcare expenses. And there was a little uptick after that, mostly because of the Affordable Care Act and Medicaid expansion. But since 2015, really drug spending has remained relatively flat. Again, as an overall percentage of healthcare expenses. Certainly rare diseases and orphan therapies, they have increased over time, absolutely, costs associated with that. But that overall budget impact still remains relatively small. We know that there are quite a few rare disease therapies at this point approved, but still, the majority of rare diseases have no therapy, unfortunately, on market at this point. Next slide, please. So since, obviously the federal government has done quite a bit with respect to rare diseases, really trying to spur growth and ultimately research and development for rare disease and orphan products. So since the enactment of the Orphan Drug Act, which is 1983, the FDA has approved 564 orphan products treating 838 rare diseases. While it sounds like quite a bit, again, this is still a small percentage of the over 7,000 known rare diseases. And that constitutes about 90% of which that still have no treatment available. So, it's really important that we continue to see this support and innovation moving forward. As we're continuing to develop these therapies, we're certainly seeing more and more access challenges being put up, especially in Medicaid, because I think we all understand that Medicaid does have this limited budget. And so it's not uncommon for Medicaid to try and look for hurdles to put in place to access, especially for some of the more costly rare disease therapies. And in fact, NORD commissioned a study 2 years ago that suggested that 61% of patients have been denied or face lengthy delays in accessing rare disease therapies that require pre-approval or prior approval. And certainly these denied referrals and some of the other access impediments are very challenging from a rare disease access and coverage standpoint. Next slide, please. I just wanted to, for all of you, kind of try and highlight some of the challenges and trends that we're seeing within Medicaid that are really becoming more and more prolific and ultimately, impacting this concept of rare disease therapy access. Kind of highlighted 3 different buckets here. The first being ICER, which I think a lot of you are probably have heard of, at least, maybe not too familiar with, but it's the Institute for Clinical and Economic Review. So it's an independent agency that does analyses and reports to evaluate the cost effectiveness of treatments. At this point, quite a few state Medicaid agencies are actually relying on some of these reports. Now, at face value, this doesn't seem like a problem, but the problem really lies in the way that ICER actually does their cost effectiveness analyses. And there is certainly a disproportionate impact on rare disease patients and therapies because of their methodology. Specifically, they utilize what's known as the quality adjusted life year, or QALY. QALYs are hugely problematic for rare disease patients because, quite frankly, it doesn't do any justice to the challenges associated with living with a rare disease, and it puts this artificially deflates the value of life to a certain extent. So obviously hugely detrimental, and a challenge that we're continuing to see, unfortunately, but obviously working with lots of stakeholders to try and mitigate some of that utilization of QALYs, and quite frankly, the utilization of ICER reports more generally. But as I said, Medicaid agencies are more and more looking at some of these and looking to ICER and other HTA type bodies for that type of cost effectiveness analysis. Additionally, beyond that, state Medicaid agencies are frankly just looking at ways that they can all out limit coverage. So per Medicaid statute, section 1927, it's known as, which is the Medicaid drug rebate program, a state Medicaid agency has to provide access to any drug that a manufacturer signs a drug rebate agreement for. And basically, the rebate agreement says, yes, as a state Medicaid agency, we will promote access as long as you, the manufacturer, provides a minimum rebate amount. And so we do this all the time. But because of that, state Medicaid agencies believe their hands are tied at times to try and limit access to some of these more expensive therapies. And so what they've started to do more and more is utilize vehicles for trying to get around some of those statutes and laws on the books that would require them to promote access. You've probably all heard by now about Oregon is trying to put forward an 1115 waiver. It's called a section 1115 waiver that would allow them to limit access to newly approved therapies that come under the accelerated approval designation. Obviously a lot, and I'm sure a lot of you are familiar with this designation, but a lot of these new innovative therapies are coming to market under this accelerated approval. And this designation is really a robust pathway, and it's really meant to make sure that drugs that are hopefully going to treat a condition that has a severe unmet medical need are able to come to market expeditiously to make sure that that need can be met as quickly as possible. It's kind of unknown at this point how CMS, which is ultimately the body, the authority that would have to approve those types of waivers, will weigh in on it. But this is becoming more and more commonplace for states to look to these types of vehicles to limit access, and it's a somewhat alarming trend that we're attempting to look for ways to mitigate. And then on top of that, the last bucket here is really just price control. So, I think we all agree we'd like to make sure that everybody's able to access drugs, and we can look for ways to make sure that they're affordable, and we certainly are looking to do so through some of our outcomes-based arrangements and those types of efforts. But states are also looking at how do we actually just put price controls in place. So they tell everybody how much they will in turn reimburse a manufacturer for. So what price, what level they're willing to reimburse a manufacturer for. The challenge there really is kind of twofold. One, I think you can imagine that potentially has the ability to limit innovation to a huge degree. Obviously, we continue to see these wonderful new innovative therapies coming to market, not just some of these therapies that are more had too much caffeine today, sorry guys. Not just some of these more chronic therapies, but also new genetic therapies as well. So a lot of these are coming to the market, and they're doing so because of the innovative environment that we foster here in the United States. Some of these efforts to really control prices are really going to negate some of that innovative environment that we are attempting to foster. And then on top of that, it obviously has this downstream impact, and probably the most important impact, which is limiting access to patients living with rare diseases. So, these are kind of, as I said, three main buckets of kind of challenges we're seeing currently in Medicaid with respect to accessing rare disease therapies. Obviously, a lot more than that, but these are kind of the three buckets at this point. But next slide, please. We'll talk a little bit more about some of the operational hurdles that we're seeing. But I tried to here really highlight a couple of these state-specific Medicaid challenges. We have seen, as I said earlier, some of these states trying to utilize waivers that really seek permission from the federal government to operate what's known as a closed formulary or a commercial style formulary, meaning they would not have to cover every FDA approved drug. Not just Oregon this year, but Tennessee actually received a partial approval for a closed formulary. Massachusetts tried back in 2017 and was ultimately rejected their application, but we're just continuing to see more and more states glom onto this concept and really see if it's a path forward for them and their belief of how they should be limiting the cost of prescription drugs. But I mean, beyond that, we're also seeing, as I said, some of these prescription drug affordability boards. So Colorado passed a prescription drug affordability board 2 years ago. Maryland did the first one, I think, 3 years ago. New York has a law in place that is reminiscent, is similar to a prescription drug affordability board. They don't call it that. It's known as the drug cap there, but in effect, it's pretty similar. And then on top of that, and Carrie will talk more about this, our rare and ready coalitions. There are some states that we're working in very specifically that have seen similar challenges or even more operational challenges to rare disease therapy access. Those states are highlighted in red there. The first being Florida. So Florida has always, and this is something we're hearing more and more, but there is inconsistency in terms of coverage criteria between Medicaid managed care and Medicaid fee-for-service, which is illegal actually as per Medicaid statute, but it is something that we unfortunately see a lot of times within states and Medicaid managed care plans. But there's a lot of challenges in Florida relative to that. Quite frankly, the same in Illinois. So we just spoke with some advocates the other day that kind of unfortunately informed us that they're continuing to see this. They're continuing to see managed care plans not even necessarily covering every FDA approved therapy or the therapies that even are prescribed. And it's alarming, and it's something that we think we need to work to mitigate. And then finally, in New Jersey and Pennsylvania, these are states that are just well known for scrutiny of rare disease therapies and high cost therapies. And so they're always looking for creative solutions to try and ultimately put up barriers to access. Next slide. But as I said, we're also beyond some of the more existential challenges from an access standpoint. We are seeing a lot of these operational hurdles that are starting to pop up more and more within Medicaid programs throughout the country. One of them being that once a therapy is approved by the FDA, specifically a rare disease therapy in this case, a lot of times there's pretty significant delays before Medicaid will even promote meaningful access to those therapies, which obviously is challenging, especially as we're talking about some of these rare diseases that really have this urgent unmet medical need. And then, we also are seeing, as I stated a minute ago, discrepancies between managed care coverage, Medicaid managed care coverage, that is, and fee-for-service coverage criteria, which again is illegal, but unfortunately, states are allowing this to happen to a certain extent, or they're just being naive to the fact that it's existent. And then finally, we're also seeing, and this is something that we're more and more concerned about with respect to some of these gene and cell therapies, Medicaid actually being more restrictive with their coverage criteria than what's actually approved in the FDA label. So looking at things like the inclusion/exclusion criteria from clinical trials and some of those benchmarks when actually developing their own coverage criteria, which again, I mean, they're not supposed to do, but they continue to do it. And so we're all trying to think creatively of what we can do to mitigate that and make sure that patients that really need access to some of these truly innovative therapies are able to do so and do so relatively expeditiously. Next slide, please. So this is time to treat, as we've kind of named it, and it's a legislative concept that's really meant to to a certain extent, mitigate some of those barriers, some of those hurdles we just talked about. It is a relatively comprehensive bill. It has not yet been introduced anywhere, but we're having a lot of great conversations about it with legislators throughout the country. But it has four main principles, and so those principles are really mandating this time frame for how long a state Medicaid agency has before they have to complete a clinical review and ultimately publish coverage criteria. And we've set that. I won't say it's arbitrary, but we've kind of come up with a date of 60 days. It's a pretty quick turnaround, but at the same time, I think everybody here understands that at times every second counts, and so just making sure that that access can happen as quickly as possible upon approval is really paramount. The next being this coverage policy not being more restrictive than the indications and usage section of the FDA approved label. We feel obviously whatever the FDA approves should ultimately be the patient population, the eligible patient population for that specific therapy. And any state attempt to diminish that is absolutely tantamount to restricting access. And so we want to the extent possible, try and mitigate that as well. The third principle here is it's kind of state dependent. And so I say that because this is specifically around step therapy. So a lot of states at this point do have step therapy provisions in place and exceptions processes in place. So this is really a principle and a piece of the provision within the legislation that is state dependent. So if a state already has it, not necessarily needed. But basically what this provision would do is create an easy exception process for step therapy protocols if deemed medically necessary by a provider. And that specifically would look like 72 hours. There must be a 72-hour or a response must come within 72 hours for any non-urgent requests and 24 hours for any urgent requests. Again, this isn't going to be in every legislative initiative depending on the state and whether or not there's pre-existing step therapy provisions in place. And then finally, really trying to create the scope of what this bill is ultimately impacting, and that's so defining qualifying rare disease, and that's rare pediatric therapies, orphan therapies, breakthrough designation, or those that come under the RMAT designation, which is gene and cell therapies. The rationale here is kind of twofold, really trying to limit the scope of the legislation to hopefully make it more palatable for a legislator, but then also making sure that it's actually impactful, right? So we're covering the therapies that really are coming to market with the understanding that they are going to help those in that category of significant unmet medical need. Next slide. I'm sorry, this is a lot of information, everybody, but we will have time for questions in just a couple minutes. Yeah, and I think this is my last slide, so this is perfect. But so we've talked about time to treat. We've talked about some of these challenges that we're seeing from a Medicaid access standpoint as it relates to rare disease therapies. As Carrie talks more about the Rare and Ready Coalition and some of the issues that specifically we'll be working on or hope to work on, it does go a little bit beyond time to treat. So Three other issues that we're likely going to activate around are, maintaining access to these accelerated approval therapies. I touched on that briefly earlier about Oregon, but just making sure that some of these therapies that come under this pathway are not overly scrutinized or even limited in terms of their coverage within state Medicaid programs. The second being really looking at how do we think about reimbursement for gene and cell therapies a little bit differently. We all understand that there's a pretty significant upfront cost associated with those, but at the same time, there's a huge amount of upside potential, partly for the state Medicaid programs, but I think most importantly for patients. And so just making sure that there's an ability to access is kind of paramount here. And these outcomes-based arrangements seem to be, to a certain extent, an objection handler with respect to some of these gene and cell therapies. And then finally, and I think a lot of you will appreciate this in the world of rare disease, but maintaining expanded access to telehealth. So through the pandemic, access to telehealth was greatly expanded across all payers. And I think, as a company, as a coalition, as a public health advocate, we're very interested in seeing this expanded access maintained and learning more about what we can do to help make sure that happens, both in terms of legislating if needed, but also working with, state Medicaid agencies, state legislatures to ensure that individuals that could really benefit from telehealth, given some of the constraints associated with rare diseases, are able to do so. So those are a few, just a quick snapshot of a few other issues that we'll likely undertake and be advocating on behalf of from a coalition standpoint. But again, I went through this really quickly, so I'm really interested and happy to answer any questions that may come up relative to anything I just discussed.
Yeah, I did have one come in.
Sure.
A lot of the concern around accessibility is dependent on what state by state will approve. What hopes do you have, I guess, by legislating on a national level for statewide access across the board?
Trying to make sure I totally understand the question. So I'll just say there isn't necessarily, it's not what's approved state by state. So, these therapies, as they come to market and are approved by the FDA, if we sign a drug rebate agreement, they're in theory approved for every state. Every state has to promote access. I think the challenge is, what does that access look like? What hurdles are put into place? And we know there will be hurdles. I think, and it was the question, what could be done from a federal, national perspective?
Yes.
Well, I'll just say that I'm not the federal expert at BioMarin, nor am I by any means, but from a rare and ready perspective, I know that we're looking at opportunities to think about some of these operational challenges in Medicaid from a federal perspective as well. The time to treat proposal itself is really meant to be state by state.
Okay.
And so we're unfortunately at times you have to go state by state for some of this. Federal overarching legislation at times is pretty difficult to pass. So this is really a state level effort at this point, with the understanding that I think we will likely kind of continue to branch out into that more federal perspective.
Another question through Facebook: how can advocates step up and get more and help more rare disease patients get approved access to Medicaid? So how can advocates step up and help more rare disease patients get approved access to Medicaid?
Well, I'm going to let Carrie handle most of this in a minute, but I would say certainly join the Rare and Ready Coalition. I think, but beyond that, honestly, you can work with any of us. There's a lot of issues, out there that we can all work on together. And I think certainly Rare and Ready working through BDSRA, because I know you guys do a lot of great work from an access standpoint as well. There's a lot of opportunities, I think, out there. And I think a lot of support in trying to promote access to rare disease therapies. But, it can take the form of just joining these calls, learning more about it, actually, approaching legislators at some point, and through the Rare and Ready Coalition, we'll certainly do trainings around that. But yeah, there's a lot of avenues for advocacy, and we're here and happy to support.
Yeah. Can you speak a bit more about accelerated access to cell and gene therapy? You may or may not know, but this is a really exciting time in our space where we have a lot of things hopefully coming down the pipeline.
Mm-hmm.
Do you have any advice for potential patients to encourage that progress?
Well, I would just say, get to know your some of the associations well, get to know some of the patient advocacy groups well. Continue to learn about what clinical trials are happening. Certainly to the extent you can, just as you asked a minute ago, help advocate on behalf of access to some of these therapies as they're coming to market. I think part of the challenge is going to be after the clinical trials happen, how do we ensure that patients that can actually benefit from these products, these therapies, are able to get them? But yeah, I think just it's always important to stay plugged in with your patient advocacy organizations.
Yeah. And Carrie, feel free to cut us off if we start running into your time. But another question that popped up: are there similar issues for employees and private insurance that Medicaid is facing? Absolutely.
Unfortunately, it's harder to legislate and make changes to private insurance. So a lot of private insurance and employee-sponsored health plans are governed by a group of laws called ERISA. So this is a federal, so they're federally governed. It is extremely challenging to make changes to those types of health plans. That being said, I think that a lot of times Medicaid can serve as kind of an example. And these plans, ERISA plans and otherwise, will look to Medicaid and Medicare to better understand what they're doing from a coverage standpoint, what they're doing from a reimbursement standpoint. And so I think while it's challenging to make changes to some of those or legislate changes, we can certainly lead the way by making changes to Medicaid and hoping that that serves downstream as an example of what should be done from an access standpoint.
Could you reference Medicaid access when you're pursuing an appeal for private insurance? Do you think that that might help any case?
I don't think it would ever hurt.
Okay.
Absolutely. Yeah.
Great. Those are all the questions for right now. Carrie, would you like to dive into your piece?
Let's jump in.
All right, let me reshare. Here. Okay.
All right, great. You can move to the next slide. Thanks so much, Morgan. Ken did a great job of really setting the stage, right? What are the hurdles? What are the restrictions that Medicaid is putting on? And it's an exciting, as Morgan said, it's an exciting time for rare disease right now. We have all this new innovation and these innovative therapies and gene therapies and telehealth and all these great resources we didn't have, 20 years ago. But what good is that if we don't have access to these therapies, right? Or access to telehealth? What good are these therapies if those, who need them can't get them, and they can't get them in a timely manner? So what we've done is we really believe that it's all about advocacy. And some of you may be new to advocacy and some of you may be pros, right? So I've been building grassroots coalitions around policy issues for over 20 years, and I've seen firsthand that advocacy can move the needle and create change. Oftentimes these policymakers make these policies and really have no idea the impact that they have on a particular community. Legislation is made and no one realizes, how it affects a particular community. And so what advocacy does is it amplifies the voice of those impacted by these policy decisions. And so what you can do is really tell your story. That's all advocacy is. is telling your story, talk about your journey. And it's a really powerful tool for just awareness. And it offers insight into real life experience. Not to mention, a legislator will remember you and your story. They're not going to remember the facts. They're not going to remember the statistics. And one of my favorites, speaking of statistics, is the fact that messages delivered through storytelling is 20 times more memorable through facts. And that's why advocacy matters. That's what it's all about. Go ahead and go to the next slide, Morgan. So there are really simple ways to advocate. And like I said, some of you may be pros at this. Just building awareness, build disease awareness, build awareness to how this policy is impacting your life or the life of your loved one. Educate, and then build a coalition. And really, that's what we're here today to talk about. So next slide, please. With support from BioMarin, we have built this Rare and Ready, a genetic condition coalition. I'm so excited to share this with you today. This coalition was really built to be able to move quickly on state-specific issues. As Ken had mentioned, we have found in our experience that facilitating change through a state level is much easier than through a federal level. And if we can get enough states to facilitate this change, it sort of gives us the ammo to then do it on a federal level. So Rare and Ready has been piloted in 4 states, Florida, Pennsylvania, New Jersey, and Illinois. So we're piloting in those 4 states, but we're hoping to grow. And so we're really just a coalition of rare disease organizations, patients, caregivers, healthcare providers, genetic counselors, anyone touched by rare disease. And we're really about getting the story out there and educating these state-based policymakers on how their policies are impacting us as a rare disease community. So currently we have 13 organization supporters, BDSRA being one of them. Thank you so much, BDSRA. And we're working together to facilitate change. One of our supporters, the Hypertrophic Cardiomyopathy Association, is in fact working on specific legislation in New Jersey called the Healthy Cardiac Monitoring Act, which they're trying to include cardiac questions to be included in the well child exam. So if you want more information on that, you can visit 4hcm.org, and I'll go ahead and put that website in the chat. But that's what we're doing. We're all working together to make change state-based for the rare disease community as a whole. And we're so thankful to be supported by BioMarin, and we're facilitated through my organization, which is called RX for Good. Go ahead and go to the next slide, Morgan. So how is a coalition different from individual advocacy? Why build a coalition when, as a caregiver or a parent or a patient, you can write a letter to your legislator? So we built this coalition because it really serves as a unified, powerful voice. Individual voices are important for sure, but this allows us to pool resources for a greater impact. It allows us to bring all these voices together to really create one powerful message, to amplify that voice. It's targeted effort of messaging. As a legislator, if you're getting 1 or 2 letters, it may not have the same impact as getting a letter with 20 organizations listed, and 20 individuals listed. That really shows this great impact and a really targeted effort of the whole community coming together because they want change on specific policy issues. Go ahead and go to the next slide. So there are real effective ways to advocate. And this was such a great question from someone that Ken answered. But, the first thing, join the Rare and Ready Coalition. We're here to help. If you've never advocated before, or you've never talked to a legislator or done a letter to the editor, we will help, we will train, we will walk you through the process. Just sharing your story and sharing your journey, whether it's a parent or a patient or a healthcare provider, is really going to make an impact. So the most important thing you can do is join our coalition. And then together as a coalition, we will meet with decision makers. We'll write letters to the editor. We'll use social media to get our message out. And during those times when they're getting comments or feedback on specific policies, we'll submit them together as a coalition to really make change. Next slide. So we all know the power of social media. It's a different world today. Like I said, I've been building coalitions for over 20 years and really seeing effective policy change. But we didn't have social media like we do today. It's such a different world in the world of advocacy on how to effectively use social media. So we have a Twitter account. If you're not following us, please do. Our handle is @rare_ready. Share our tweets, repost our tweets, like our tweets, hashtag your way into the conversation. When we meet with legislators, tag your legislators. Many of you are members of private Facebook groups. On those private Facebook groups, talk about the Rare and Ready Coalition, talk about the journey in your state and any Medicaid access challenges that you have in your state, and share those with elected officials. And then Instagram is so great on telling your story. Again, your story is 22 times more memorable than a statistic. And Instagram is a great avenue to share that story. Take a video of, a typical day, or how Medicaid or private insurance specifically can impact your life because they're restricting access. Share that video, to tell your story. And we would be happy to share it as well. So really using the power of social media, it really helps with our advocacy efforts. Next slide. So what can you do tonight after you leave this webinar? The first thing you can do is you can contact me if you're interested in joining the coalition. There is no time commitment to join. As I said, I have rare disease in my family. I certainly understand every day is unpredictable. So we're not asking for a particular time commitment. We're not asking for a financial obligation. We're just asking for you to be a member and give whatever you can give. And then ask others to join. Share that you joined. Share it on your social media. Talk to your friends and family and those in your private Facebook groups and let them know Rare and Ready is there. And then tell your story. We're talking with advocates right now in Illinois who have such just horrendous Medicaid stories. We're going to be sharing them on our Twitter channel, so keep an eye out for those. But just sharing those stories, we're putting a face, we're putting a human element to what really goes on. And this will allow us to make some real change when we meet with decision makers as well. And I already talked about the power of social media. So use social media and use it effectively. So these are really concrete steps on what you can do after this webinar tonight to make a difference and move the needle on these restrictive, really detrimental Medicaid hurdles that have been put in our place in front of us as a rare disease community. Next slide. And policy changes don't happen quickly. Keep that in mind. Having these treatments out there is such a blessing and can really improve quality of life. But keep in mind that we may be in this for the long haul. And when we're growing fatigued and we're growing weary, we have to remind ourselves why this is important. And we're going to be celebrating small victories along the way. So we're not going to be overnight success. We're not going to make huge, policy changes, but the small victories will all add up and will give us, those little wins that we need to make a difference. And once we can make a difference, in these 4 states, then other states may follow suit. And it's sort of like a domino effect. So just know that we're in it for the long haul, and that we need to celebrate the small victories together. Next slide. That's it for the Rare and Ready Coalition. Again, thank you so much for taking the time to join. I'm happy to answer any questions that you have about joining the coalition or what we're doing, or if you have more questions for Ken, just let us know.
You're on mute, Morgan.
Thank you. We received a couple in our Facebook just asking about joining and more information. Is there a website, or is it just email based right now? What's the game plan for folks who want to engage?
Great question. So right now we're building the website. We've had such excitement that we're building a website. So right now, just email me. I'll go ahead and put my email in the chat. And you can also contact Morgan to get my email if you don't get it from the chat. Email me. I'm facilitating and organizing the coalition, so I'll get in touch with you immediately. Follow us on Twitter. You can DM us through Twitter, but we will have a website, and I'll keep you updated when that's up and running.
Okay. And then are you open to folks who are only in those 4 states, or are you hoping to spread a wide net?
Great question. We are open to everybody. We are and all diseases as well. So right now we are legislatively focused on those 4 states, but we're certainly recruiting and encouraging everyone from all states to join us, because we'll eventually make it into your state and we'll need your help.
Okay. And then what kind of tools are you hoping to equip folks with so that they can kind of spread out, help raise some noise or make some noise?
Mm-hmm. So the first thing we want to do is we're in the recruitment phase. So we're sort of building our army right now, I like to say, building the Rare and Ready Army. So we're in recruitment phase. And then phase 2 will be education. So we're going to educate you on these specific issues so that you know what is happening in your state. What are the policy issues? And then once you feel educated through, a webinar, infographics, we'll then ask you if you want to meet with your legislator, and we'll help you with that. We'll help you draft talking points, and we'll walk you through what it means to meet with a legislator. If you're interested in writing a letter to the editor or telling your story, we'll walk you through that. We'll help you draft talking points. So we really, hold your hand and walk you through every step of the way, because I know advocacy can seem intimidating, especially if you've never done it before. And so Ken and I have been in this business for a long time, and we're more than happy to make you feel comfortable.
Yeah. What are some of the things that Rare Ready is working on currently?
So we're focused currently on those 4 states, and as Ken had mentioned, he's really working on this time to treat legislation. So legislation has not been introduced yet in these 4 states. So like I said, recruitment is number 1. So if you want to help us with recruiting your friends, your family, other families that you know, that would be really great. Education is phase 2. And then phase 3 is really activation. And that's when, once we have the legislation in states, that we're going to call on you to write a letter or meet with your legislator. So right now, helping us in recruitment, sharing social media, and telling your story are the top 3 things you can do to help.
Okay. I know that currently you're partnering with BioMarin. Can you talk a bit about your philosophy as far as working across the board?
Across the board
With
other pharmaceutical
partners?
companies?
Yep.
Oh, sure. So the coalition, although supported by BioMarin, is facilitated through RX for Good. And so our members, like I said, we have 13 members, really determine the agenda. BioMarin supports the coalition, and we're open to working with other industry as well. This is not a territorial thing. We are about all rare diseases, and we're about access to all treatments, not just BioMarin treatments. We're about access to all treatments.
Okay. Do you have any other questions, any other comments? Final closing remarks? I don't see any more questions as of right now.
You want to go first?
I would just say thank you to everyone for having us here today. We appreciate your participation, your support. We know you're all doing great things, and we know you're all really busy. So thank you for being here. As Carrie said several times during this, we're here to be, not only as a coalition, but also as a way to support you and your efforts to really try and promote access to some of these innovative therapies, and make sure that you as parents, you as patients can ultimately get your hands on something that's really going to be profoundly impactful. So.
And I echo Ken's comments. Just a heartfelt thank you to BDSRA for all their support and for having us tonight. I thank the 13 member organizations who have joined the coalition already. And really from the bottom of my heart, this is an issue that's so important to me and touches my family. So thank you for joining us today. And I look forward to hearing from you all about joining the coalition.
Wonderful. And I would also like to thank everyone for joining us tonight. If you have questions or would like to get connected to either Ken or Carrie, please feel free to shoot me an email. I'm happy to connect you by email later on. And then if you have any questions about what our partnership looks like with Fair and Ready, I'd be happy to answer those. Otherwise, I would just encourage you to continue to look at our Illuminator, at our Toolkit Tuesdays for additional advocacy efforts on our end. And I would just like to thank you all and wish you all a happy night.
Good night, everyone.
Thank you.